This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Hi, I'm David Cognetti. I'm an associate professor and head and neck surgeon at Thomas Jefferson University in Philadelphia, and I'd like to welcome you to episode 14 of the American Academy of Otolaryngology Head and Neck Surgery COVID podcast series. I'm excited about this episode because it covers a unique situation with a group of otolaryngology residents who volunteered in a COVID-19 surge ICU at Elmhurst Hospital Center in New York. We hope that the experiences shared by these residents will be informative to the membership regarding potential hurdles and pitfalls that they encountered in this scenario, including covering other specialties than our own. So I'm joined by Arvind Badi, a PGY5 resident at the Icahn School of Medicine at Mount Sinai in New York, as well as Usman Basharat, who's an intern in that same program. And as I mentioned, they had experiences at Elmhurst. So guys, you know, all of us across the country have watched with interest the COVID situation in New York. And from what I can tell, Elmhurst was the epicenter of the epicenter. So why don't you tell us some of the early ons, what was going on there, and when you guys recognized that you were in a pretty advanced situation?
Sure. Thanks, Dr. Cognetti, for having us. And I guess, Usman, I'll start a little bit about what we saw as a team, and then kind of go through how things changed. So myself, Usman, who is the intern on the service, and two other residents were the residents that were at Elmhurst just on a regular ENT rotation. And over the span of really maybe about a week or a couple days, we had actually just all changed rotations sometime in early March. And we had started to hear kind of the whispers of things changing, lots of infections happening, kind of all, you know, everything that was happening in Italy. And very quickly, in the span of a few days, even our site director told us that we would have to cancel our clinics. All of our elective cases were being canceled, and we had to reschedule all of our clinic cases for the next week, as well as all of our clinic visits. So that's kind of how it all started, where we just kind of got a lot of administrative keep patients out of the hospital type of queries, and then very just, I feel like exponentially similar to, you know, just the spread of COVID. Every single part of the hospital started to change in the span of days, where there was a lot of building management people around, a lot of nursing administrators and hospital administrators, more or less like coming in and out of our clinic rooms and coming in and out of different parts of the hospital. And I think now, looking back on it, they were probably looking for places where they could place patients. And for that first week, we were very kind of segregated or kind of cordoned off from everything that was happening the floor below us in the emergency room. But very quickly did we kind of start to see how it changed. I don't know if Usman, you want to comment a little bit on what you saw?
Yeah, I think similarly to what he's saying, we were seeing like downsizing of just our own clinical volume, but even, you know, as a person who was kind of fielding all of our consults, I think just in the ENT realm, I think there were fewer patients that wanted to come in for their own ENT problems when we would call them to, you know, check in like via telehealth. Suddenly their problems were going away, because I think a lot of patients were worried about coming to Elmhurst, because everyone was finding out that this, you know, it's really COVID central here right now, and they wanted to avoid this place as best as they can. Our consults coming out of the ED had also just kind of over the span of a week just took a nosedive, like we weren't getting anything. And I don't know if people were also being rerouted, or if they were just avoiding coming to the emergency department, but definitely just in the entire ENT realm, our clinical volume just kind of became very much reduced. And for us as residents, you know, we started to also, we could basically run a skeleton crew at that point, because our own responsibilities, just there was not very much going on at this site, particularly with ENT.
Yeah, so you're both residents, and as you referenced, the volume of typical residency experience quickly dropped, and a lot of programs were advising and very quickly pulled medical students and residents out of frontline care, certainly in the outpatient setting. So why don't you describe the process of where you went from low volume, protected from COVID situation, really to putting yourselves on the front lines?
Sure. So I think this is where kind of the I guess the story, so to speak, begins. Is that so we similarly, like a lot of the other programs, I think at least in the region, were kind of pulled, like Usman had mentioned, into this kind of skeleton crew where a lot of us were alternating days that we were going in. I was trying to limit the amount that all the junior residents were going in to the hospital, and we were really staying at home doing our virtual learning and stuff like that. And our site director had sent out an email asking us to see if we'd be willing to volunteer in any of the possible roles that Elmhurst had started to need more providers for. And those options were like, Elmhurst was one of the first hospitals that put up that big kind of tarp tent outside the emergency room. So there was the option to go there, to swab patients, to take vitals in the emergency room, or be part of the ICU. And the reason that I actually responded to that email was because my wife, who is a medical student, had already volunteered to be part of this group of medical students at her medical school that would go on to a COVID unit, as all the other students were kind of being pulled back. And I kind of was like, my wife is definitely my better half, and kind of pushed me to. I don't know. I think in this time period, in that week or so where we were deciding kind of what to do, I'm also not one to where I think every resident and every surgeon was kind of getting antsy just staying at home watching virtual lectures and seeing things happen around us. So as a result, that week I emailed our site director and I was like, I think I'd be happy to volunteer in the ICU. Can you put me somewhere? And then within hours, I got an email back from the ICU administrator and the head of the surgical department asking me. She basically gave me a list of like every single shift from now until like 3 weeks from now. I was like, which one of these can you do? And what I did was I actually paired myself with Usman, who was the ENT intern on service and was taking call at Elmhurst for ENT trauma because we still needed to be in-house. We were still dealing with surgical airways. So as his chief, I kind of needed to be his backup no matter what. So I was like, let me just be in the ICU on the days that he's in the hospital dealing with ENT problems, so we can kind of be together, but also pull double duty almost. And that's kind of how it started. Usman, you want to comment on how I reeled you in?
Yeah, definitely. So, I mean, I'll be honest, in the beginning, when the idea of volunteering got thrown around, my gut reaction was kind of just to shy away from it. I figured there's other providers that are probably more suited for managing ICU patients, and maybe at some point we all figured that we would get redeployed in some capacity. So I figured, at that point that I would just wait and see what happens. And so like Arvind was saying, he was pulling double duty, kind of, being my backup while I was taking call. And it was during his first shift, I would kind of go in and out of the ICU to talk to him and kind of see what's happening. And then his next shift, I think he was by himself, and he had he was in the ICU and there was a bunch of patients, and I figured since I wasn't doing very much in the ENT side that I would just kind of pull double duty that day and just work in the ICU with him, and just go in and out whenever there's some sort of ENT need, which there wasn't much of at the time. And so at one point, I think when we had an admission, I got a chance to go down to the ED, and that I think was one of the first times that I got to see the ED at its like peak COVID level, and just the sheer volume. And like I remember seeing in the trauma bay a row of patients all intubated, just waiting for ICU beds. And so that's kind of, I think, seeing it all firsthand, like kind of really highlighted that there was a need for somebody, just whatever provider is available, to take better care of these patients, just because it was very, very overloaded downstairs. And so that's kind of what motivated me to kind of fully take on this ICU volunteer role, and help, I guess, in whatever way we could.
Really impressive, your noble decision to both volunteer in a situation like that. And I hear that story of the ventilated patients lined up in a trauma bay, and probably many of our colleagues across the country in situations where we were able to keep below capacity are fortunate to not have felt to be in that situation. Maybe you can share some more early experiences of what you witnessed or some of the challenges you faced in the ICU as this first started.
Yeah, so I mean, I think Usman describes it very well, and even just reading some of the notes that we both took about those first couple days, because actually the first week or so, I did a 24-hour shift by more or less like by myself, and then a day or two later, him and I were together in the unit, and just listening to both of our experiences, I think thinking back on it now, there were so many parts of it that at that point seemed so extreme and so crazy, but after like a few weeks seemed normal. Our unit or the version of the unit that we had initially was we were in what was the PACU, and I was managing one like patient that was actually meant to get transferred to another hospital. It was a COVID negative patient, but just needed to be transferred out, and that's kind of how our unit started. And then over the span of like 6 hours, all these building managers came in and put these like there's like these giant like jet engine type like HEPA filters that they plugged into all the walls to create, I think, a version of a negative pressure unit, and then kind of plastered off the version of the nurses stations that we had, and it was just a package, so they weren't separate. That was, I think, the thing a lot of people didn't realize until they came to the unit was that the patients weren't separated in rooms because this was a surge unit, so to speak. It was just one giant room with a whole bunch of patients next to each other. So just seeing them kind of construct a unit in the span of a couple hours was pretty crazy. And then that first night, the following morning, Usman and I drove home together, and I think he can probably describe it actually better than I could in my own words. But I was just so burnt out and shocked and traumatized, and I went home and I just like slept for hours and got very emotional and was extremely frustrated at everything that I had seen. And the big thing was that trauma bay, we see the trauma bay and the cardiac bays, we see like every single day when we're on call. And there's usually, 4, maybe 6 patients in there. 2 of them are traumas. Maybe 1 of them is intubated. But this was just like one poor emergency room resident and an ER attending, and just like, I don't know, tens of rows of patients, and just every single monitor going off at once. And I just looked at them, and we transported 1 patient, and they were so happy because I don't think they'd transferred a patient to an ICU in at least a week and a half. So they were just like, just take this person, like, take them to a better place that's not here for now. And that was really, really scary, and something I'd never thought I would see. And, doing some medical mission trips, it was really, for the first couple weeks, that's really what it was like. It was like being in a disaster zone or in a war zone, where you thought to yourself, like, I don't think I have ever seen anything like this, and I don't think we ever will. And I think the first week was just like fear and being burnt out and really being frustrated at everything that was going on.
Yeah, I have to give a lot of props, I think, to the ED staff, just with the sheer volume that they were having to manage. When we first, I remember walking into my first kind of official shift in the ICU, and I remember before I could even log on to a computer, I look up and I see Arvind doing chest compressions on a patient. Like, there's a patient already coding. This is within 3 minutes of, getting in there and starting stuff. And then he's yelling at me across the room, like, hey, get the family on the phone. And a lot of the staff that were in this ICU were not, they were kind of visiting or volunteer staff from other parts of the country, not used to working in our hospital. And so it was really, getting everyone up to speed. We had a couple of PAs around as well, and just it was trying to get up to speed ourselves while simultaneously making sure that everyone who's working around us is also understanding, where do you find things and how are we going to, basically run this service. I remember the first day, I think we were using, in addition to everything that Arvind described, like all the changes happening, we were using these machines for ventilators out of our operating rooms at first. And then we had an intensivist come by saying that, these aren't going to be sustainable for long-term use. We're going to have to find replacement. And then the next, within a couple of hours, we had these military portable vents that I don't know where they got from, but they were bringing in, and now all of our patients were getting switched over. So it was really kind of a very chaotic scene. And then I think maybe we'll get to this later, but when we started to develop our own ENT run ICU, we started at first down in the emergency department because once they were getting our space all set up, which basically they had to run through the same things like installing those giant HEPA filters, and because it was going to be one shared space. At the start of that shift, we actually started down in the emergency department because all of the patients who were going to get transferred to us were still sitting down in the ED. And so, we got to work out of the ED for about half a day. And I think that might have been the most chaotic thing that I have ever seen in my life. You walk in and it's like, it's just alarms it was basically deafening alarms from all corners of this giant space. And it's imagine a constant tinnitus that's so loud that you can hardly hear your colleague next to you. And you're all PPE'd up and you have your gown, mask, face shield, everything, and you're shouting at each other. The nurses are running around and trying to manage whatever they can. And a lot of times if we needed something for one of our patients, that was the first time that I did an A-line stick because we needed an ABG on one of our patients. I can't find the nurse, and I'm sure she's busy with another patient across the room. And so I just had to go grab the materials myself, learn how to do it right then and there. So it was, a lot of troubleshooting and learning that happened, where we typically stuff that we don't typically ever have to even think about. So it was kind of a very, I think it started off very chaotic, but I think we got used to it as time went on. And I think as we became more organized, it also settled down for us a little bit, which was nice, but definitely at the start, there were some crazy things.
That's really incredible, guys. And I can tell you, just listening to this, that a lot of people would hear this or see what you saw with regards to the sheer volume of COVID patients and doing chest compressions and everything else, would think about their own risk of exposure and back away from it. But as Usman referenced, you guys did not do that. Instead, you stepped it up a level. And this led to the development of an ICU that was run specifically by otolaryngology residents, which I think is absolutely amazing. So can you guys describe how that came about and how you prepared for that?
Sure. So I think that Usman, historically, in the span of the past 8 months, loves to sell himself short, as he's been my intern for 5 months at this point. But after that first shift, I was so burnt out. Not, like you're saying, the exposure to the disease and all the patients and the ER, all of that was so difficult and challenging because I think as ENT residents and as surgeons, very rarely are used to being alone. And I think that a big part of that challenge was it was kind of just me and a couple team members that I had never met before. I don't know their skill set. I don't know what they're comfortable doing, and I don't know what is okay to ask of them. And then the following day, Usman really, for lack of better words, saved my life. I don't know, saved my soul. I was so crushed after 24 hours that if it wasn't for him, I probably would have definitely not gone back, definitely would have quit. But after seeing the two of us work together, like he was saying, that first shift, we've had some experience before on a team, and I was just like, wow, if there's at least one person that I can trust that's on the service, it doesn't really matter what the task is, like I know I can, whether it's like giving him baseball signals because we can't hear each other, or just like telling him to do something, there's never a question in my mind that he'll be able to do it. And after a day or two of doing that, we kind of realized, what is it about us as residents or as team members that makes us functional? It is our understanding of anatomy and our training and our teachers, but I think a big part of what we gained as a very large residency as well is that our team is the only real thing that keeps us going and allows us to function at the level that we do on a regular basis. And I think that over the span of the next few days, seeing that it seemed that the highly functioning teams, and speaking to some ICU attendings and some ER attendings that I knew around the New York City metro area, and asking them, what do you need? Like, what is it that you guys really need? I know you need vents. I know you need medications, et cetera. And they were kind of like, we just need skilled providers that can follow instructions and work together. And I think that seems like such a small ask, but I think that for us, all of us, we're not necessarily skilled providers, but we are residents that work well together. And I think that was kind of the thought process. I was like, if we're going to sit here and suffer and watch these patients suffer and be alone, I think the only way we can do it sustainably is as a team. And what more comfort would I have than handing off my patients to Usman or to one of the other ENT chiefs? And I kind of told the surgical administration, I was like, I think I can get a group of residents, some number I don't know yet, that would be willing to run this unit 24/7. And based on the number of beds, et cetera, like we can, I felt like that was the one thing that we could do for our colleagues in the ER and the ICU, is say, we have a lot of warm bodies that are willing to help and willing to learn, and just do what you tell us to do. So just, we'll be your team, just put us places. And I think that's kind of how it started.
Yeah, I would echo that. I think definitely having Arvind around, like I can't imagine doing those shifts by myself or not having, it's just nice to have somebody who you know and trust and you work with. And it's also, we're all colleagues and we all are friends as well. And so it's nice to have someone else there with you throughout the day, somebody who you can kind of, at the end of the day, decompress to as well, talk to. And so I think early on, like when we were doing our shifts that were kind of a little bit more sporadic, and when we weren't there, it was other residents from other random services who would be assigned to cover the ICU. And so giving the sign out there and then receiving sign out the next day. And I think just due to lack of consistent teams, I'm sure like sometimes there were tests being ordered and then we would come on the next day and then we would have no idea, why was this thing ordered? And there just needed to be another layer of structure added. And I think it was probably best for the patients. And I think even for our own workflow, it was going to make things a lot more efficient. And so that's where Arvind had this idea of, maybe if we can get something up and running that's all of us ENT residents who we all know and have comfort working with, it might be better for our patients and just even for ourselves as well. And so I think that's where kind of the idea came about. And initially, we actually thought that we would be running the current ICU, which was already a surge ICU, but the administration was able to create a whole new space for us in the pre-op area, where they said, hey, just because there was still a need and there were still backed up patients in the emergency department, they're like, hey, we can create a brand new ICU for you. We will have other people running, coming in and they can do whatever they want in terms of running this one. But what if we created another one for you? And now we have another group of patients who were able to get out of the emergency department and decompress that further. And we thought, that's great. That's exactly what, we want to contribute towards. And so I think that's kind of the motivation for the idea of getting our own ICU up and running.
It is just incredible. And I think that message of the importance of team couldn't be emphasized enough. And hopefully your colleagues and resident colleagues across the country are listening to this, because the ability to work with each other and rely on each other is the foundation of successful residencies and teams within residencies. And for you guys to recognize that as a critical component during a crisis is commendable. In fact, some would argue that team component and the ability to rely on each other is even more important than expertise. However, in a crisis, you have to be at least somewhat concerned that you don't have the expertise for this. I know I certainly would, and perhaps other colleagues across the country are wondering, how did you throw yourself into an ICU scenario without necessarily that level of training or background? So what did you do to prepare?
So I think the nice thing about Elmhurst as a institution and as a hospital center for us as trainees is that it really is, it kind of services some of the most complex and kind of disenfranchised patients in our residency in the New York area, maybe even arguably in the country. And I think that as a result, the ICU administration there, this is like the concept of, I guess, disaster medicine or treating patients that are not your kind of standard, I guess, bread and butter type patients is like everything that they do. It's like comes second nature to them. So I think it seemed like in the New York City area, it wasn't that that the ICU attendings were overwhelmed with the concept of COVID. I just think there weren't enough of them. There just weren't enough highly trained ICU attendings for the amount of patients that were coming into the emergency room. That being said, the attendings, not only the ICU attendings, but our ENT attendings at Elmhurst and those that came to staff the unit, I think everyone kind of came in with a very similar understanding. And that was at least every single day that I was training kind of new residents to come in. We did our own version of, how to manage event, how to put in an A line, how to treat patients for X, Y, and Z things for COVID, how rounds work, how to manage blood gases and things. And we did I think that now it seems that almost every institution has some version of your quick and dirty COVID management strategy. And I think we did all of that. But the big thing that I think Usman and I, as one of the first teams, told every team that came on was that we in no way, shape, or form were going in there to think that we were heroes or that we understood anything more than anyone else. We were just like, understand what you don't know. You don't know what you don't know. And there was a lot of, I think, support because the surgical administration at Elmhurst understood what we were doing and didn't want us to feel like we were alone or abandoned. I mean, I think that every single day we rounded with a surgical attending, an ENT attending, as well as an anesthesiologist. And then in addition, we would have the surgical ICU fellow or the surgical ICU intensivist as well do multiple kind of mini rounds with us, where it would be like myself or myself and the ENT attending going around asking them multiple questions about all the patients. And I think that helped us because I think the benefit of our unit was we were never sure at all what we were doing. And as a result, we never got lulled into this sense of security being like, oh yeah, we got this makes sense, etc. Because things were changing so rapidly that we didn't have time to not ask questions. Every single hour there was something new, or we were deciding a new type of anticoagulation, etc. And I think that understanding whether patients were getting better or worse was, like you said, that was kind of the foundation or the most important aspect. And then the specific medicine behind things, we were always just, every day there was like an hour conversation with infectious disease, an hour conversation with renal, an hour conversation with cardiology, where we would just go through every single one of our patients. And I think that it was clear that those other services were also overwhelmed. So to hear Usman's voice or hear some of the junior resident's voice and say, hey, this is Mrs. or Mr. So-and-so, I spoke to you about them yesterday or 2 days ago, these are the most recent updates. That's just a consistency thing. And I think that alone is really what our strength was. But we had a lot, I can't overstate how much I think administrative and attending support we had to allow us to go into this without fear of doing more harm than good.
Yeah, I think I was pretty scared in the beginning when we decided to get our own ICU up and running, and the thought of possibly being there overnight by myself. Like I had done these shifts with Arvind around, and like there was a lot of support around, and at first, I think it was pretty daunting to think that, okay, there might be a time when now I am in here by myself, and now I've seen these patients crash before my eyes. And so what if I am the only one there? Like, how am I going to manage this? And I think in the beginning, like Arvind was saying, like we had some sort of a crash course. I went to one at our Mount Sinai residency. They had the intensivists there were basically like hosting these small sessions where they would go over brief, like 30-minute to an hour training. And so, doing whatever I can ahead of time. And then even amongst ourselves, we, once we had our team of residents ready to go prior to us starting, we held a Zoom session where we went over all of our learning points. And I think it's also another thing to have other people, like other residents in there who are reliable, because we had another resident on our team, and I think he would go home and he would do a lot of research, and he would come up with like little learning points, and he would email them out to the whole team. And so I think while it was daunting that, this isn't our specialty and this isn't what we're trained to do, having other residents who I know are very competent and it seems, very motivated to learn more about this disease process, teach ourselves, teach others on our team, and make sure that we are doing the most that we can to provide good care for our patients. That was at least very comforting. And then, like Arvind was saying, a lot of it was also just learning on the job. And whenever that intensivist would come around, the one who was floating from ICU to ICU, we would just make sure that we picked their brain as much as we could about whatever questions that we had that we felt like was above our level and that, we had uncertainty about. And then I think they always really welcomed the questions, and they seemed like they were really interested in teaching as well and giving, their learning stuff day to day, and there's new research coming out from, I'm sure, their intensivist world about how to manage these patients. And they really like to share that with us too, as long as, we expressed interest, because we wanted to know. We had no choice either. We're dealing with these patients. So I think they were very, very welcoming and very approachable. And so I think all of that kind of put me at ease, at least, to going into, every shift, knowing that I had that support.
Just absolutely incredible. Let's hear a little bit about what was going on outside of the hospital. So how did you guys work the balance? Give a little insight into your daily routines, or how you manage concerns for exposure of family members or fellow residents. How did you cover those concerns?
So the nice thing was that I think that in addition to us kind of, being in the ICU and working kind of really difficult and long hours, we also had a lot of support from our kind of our program director, our administration, our program, as well as our co-residents, where in addition to us kind of managing the patients, we were getting a lot of information on a daily basis. A lot of it initially was about how to protect yourself, how to protect your family, how to properly don and doff PPE. So I think that early on, maybe the first week or so, we just had like 3 or 4 just Zoom lectures on how to do those things properly. And I think every single one of us had some version of like multiple different zones. I was like very lucky. I was able to kind of get rent a car for the month or month and a half or so that we were in the unit. And my car was kind of my intermediate, whatever, yellow zone, so to speak. So nothing that I wore in the unit ever really actually left Elmhurst. Like I kind of changed all my scrubs and everything as soon as we were done with the unit. And then every kind of additional, gloves or mask or other things that I was wearing in and out of the hospital would stay in my car, and then I would change again from my car to my house. And then I think every resident in the program, regardless of if you were in the ICU or not, if you were seeing patients, everyone had kind of a version of an intermediate zone in their apartment or outside of their apartment, where like you kind of take off all the things that you had, go straight to the shower, take a super hot shower and stay away from your family, and then kind of go back. I think that, unfortunately, neither of us can really speak about it too much, but there was a lot of challenges with a few of the residents that actually had children that volunteered in the unit. They had families, and 2 of them had very small children under the age of 2, and they were both very anxious about it. But I think that they also, I just think were more even more diligent about making sure that they weren't bringing it home to their families. And I think the way we did that best was we just watched each other every single step of the way. Like all of us were always putting on PPE together and removing it together and exiting and entering the unit kind of in pairs almost, to make sure that we weren't contaminating things, that we weren't spreading things. And there was always someone assigned every single day to wipe down like every single machine and every single cell phone and every single portion of our common areas, just to make sure that I don't know if I'm wrong, but I think I'm right in saying that at least thus far, all of us that were involved in the unit did not, or thus far have not gotten sick. So I think that's a testament to how much we were diligent about staying protected.
Yeah, I mean, I can speak for myself in that I live alone, and so I think quarantining off myself, and making even the decision to volunteer was, in that sense, a bit easier for me. I think if I was living with my parents or somebody else, I don't know how. I honestly don't think that I would have volunteered in that setting, and so I have to commend the other residents who did live with their families and did still step up. Because I think it takes a lot of courage to be able to do that. For myself, I think it was just, how Arvin talked about just being diligent about making sure that we have the proper PPE on, which thankfully, our hospital, I would say, did a good job in providing us our PPE, and then just changing out the scrubs and going home and just decompressing afterwards. I think life afterwards, it was just phone calls and, you don't meet up with anyone, but I could still talk to my friends and decompress in that way. But again, and I was also fortunate because one of our colleagues who had a car was able to carpool with me. Otherwise, I would have had to take the subway, which probably is not the best idea in these times. So it was nice to be able to carpool and go to and from our shifts that way.
Great. I should tell the audience listening to this podcast that this recording was scheduled to start at 7 p.m. And that time corresponds to when New Yorkers cheer and celebrate for healthcare workers every night. So we actually had to delay the recording a few minutes because it could be heard outside of your apartments. And I will tell you that's applause that you two both well deserve. Why don't you share some other feedback that you've gotten along the way for your efforts at Elmhurst?
So I think what was, Usman mentioned it a little bit earlier, but I think that at one point I actually felt like the most, the most proud I was during our time in the unit were two separate instances. One was at some point in time, disaster relief and FEMA and a lot of different outside services that were government-based came into the hospital. And one of them was like the Navy and the Army were dispatched to different public hospitals in the area. And there was like a Navy service that came into our unit. It was two Navy trauma surgeons who were critical care attendings, I think in Kalamazoo, and then their whole team of multiple different nurses that were all critical care trained. And they, for a brief moment in time, we were like, oh wow, are you guys gonna be in the unit with us? Like this is gonna be great. Turned out they were also moved to create another unit of their own. But after we spoke to some of those attendings, even for a short amount of time, they reiterated what we thought was true, but we needed kind of the military almost to tell us that was the case, is that they had told us about, war stories and, their times in Kandahar and in the Gulf Coast and all these really dangerous situations. And he just kept on saying that they are just an extremely high functioning team. They trust each other. They do everything as a unit. And I kind of was like, we are in no way, shape, or form close to the military, but I just think that mantra and that foundation was a really important part of what we were doing. And I think that was a really proud moment for us. And then I think the other feedback that we got that's a little bit more kind of hits home for a lot of us is that I think that in critical care, some of us have dealt with family members or friends and stuff that have passed away. And so much of that involves the family and the physician and the nurses at the bedside seeing these family members. And for us at Elmhurst and in New York City, because of this state of emergency or whatever, was it no patients were allowed to come no family was allowed to come to the hospital at all. least of all on our unit because it was one completely closed, multiple patients in a single unit. And they also, as patients passed away, they weren't able to pick up the bodies of their family members soon after. And I think the feedback that we got, or at least the feedback that we gave to each other, was that, Usman and Benny, one of the other residents that was on my team, they both were so aggressive and diligent about making sure the families could get on FaceTime or phone calls to let them see their loved one before they were kind of prepared to go off to the morgue. And I think that in a hospital like Elmhurst, in the epicenter of the epicenter, you would think that, this is disaster medicine. You do as much as you can, and you just keep on going to the next patient. And I think that a big part of what we were able to do is give these patients back a little bit of their humanity in this time of crisis, where I think there were sadly, probably a lot of patients in other countries, even in a hospital center, et cetera, that maybe weren't able to, their families weren't able to say goodbye to them, or we never found out their name. But, I commend the junior residents for really spending hours and hours going through patients' belongings, calling social workers, calling, 10 different family members who all seem to be connected to this one patient to find out, like, that this patient had a name and this patient had a wife, and, to get all of these pieces together before, if in the event they passed away, before they passed away, to at least give the patients what we would have thought would be their final wishes to communicate with their family. So I think that was really powerful, and I think that a lot of the attendings and nurses saw how much the junior residents cared about their patients, even though they had never spoken to their patients, they had never seen them awake, but they, I think they knew more of the story of these patients than any of their other patients, which is really remarkable.
Yeah, I've remained at Elmhurst since we've switched back to now covering ENT, and even when I see the intensivists walking by in the hallway, they always point us out, and they're like, "Oh, hey, how is everything?" And and they always commend us for the work that we were able to do, and I think it's always nice to get that feedback. The other day, I was called back into the ICU for a consult regarding a trach, and so when I went back in there, I saw one of the intensivists who we had kind of worked with in our time in the ICU ourselves. And so this patient we had actually taken care of for the month-long period that we were in there. And she had now had a trach, and so she was awake. And I had never seen her awake before, but the intensivist, she kind of made sure she personally took me to the patient, and she's like, "Hey, I want to introduce you to this doctor. He took care of you for the whole month that you were asleep." And she kind of made sure to make us feel like this is that it was we were able to get this patient to this point where now they're awake, after going through so much, after how Arvind was saying, we talk to the families, and it's it can be heartbreaking at times, and the family is trying to get their own closure, and you're not sure if they're going to make it through to the other side. And now to see this patient awake and be able to communicate with them, it was a really good feeling. And the feedback, honestly, even from when I go down to the ED, and I think Arvind can maybe more speak to this because I think he's had some more personal interactions with the ED staff, but whenever they find out that we're from the ENT service, they're like, "Oh, you guys are," because they remember us from when we would be admitting those patients that were lined up. And so I think they're really, really thankful. And honestly, I think at the end of the day, they were the ones that were carrying this large burden, and we helped out in a small way, but I think it was still really impactful.
Absolutely inspiring. And we're thrilled to hear that the situation has improved, and that's allowed you to resume more normal duties. Any last things, words of advice for other otolaryngology departments that may face a similar surge in the future?
So I think that, like Usman was saying, I think that even in this time of crisis or disaster, I don't think that, at least I think early on in the crisis or in the pandemic, all of us very quickly thought we're subspecialty surgeons, we have very specific set of skills that may be needed. We still have our own patients to care for, et cetera. But I think that very quickly, at least for us, we kind of turned it around to remind ourselves that while we are subspecialists, we are also just physicians and doctors like everybody else. And we all kind of went into this for a specific reason. And that was because we cared about patients, and we didn't want to see patients and families hurt. And I think that was kind of the big nidus for us was, I think that we kind of had two different directions that we were being pulled in. One that was, our education, our futures, our safety, et cetera. Then the other being, if you took a moment to see what we saw or even listen to this podcast and get an understanding of how much other people were hurting and struggling, I think that anyone who went into medicine, who cared about other patients and other people, could see that all we were trying to do, and I think what we successfully did, was help our colleagues that didn't get breaks, that didn't have people to switch with them, that didn't have a big team, that were just kind of alone. And I think that we really came together. And I would say that for other otolaryngologists that are out there that even have the concept, I think that you'd be surprised how far I think a small amount of the empathy that I know we all have and the altruism that we all have would go, even if it's something as simple as some of our attendings went to the emergency room just to do tests, just to do nasal swabs, which is such a simple thing for us, but can really decompress an extremely overburdened system. And I hope that the rest of the country will not have to deal with that. But I think that just remembering that we are physicians first before anything else, I think is really important.
Yeah, and I think specifically talking about maybe, other services have to cover the ICU, I think it's just trusting, because in your own medical abilities, at some point we all learned the general medicine that we need to learn to become doctors. And at the end of the day, it's the same disease in this, and it can be a very complicated disease, but it's the same thing that you're treating over and over. And so once you give yourself a bit of a refresher and you review certain concepts, I think just trusting yourself that you're going to be able to provide care for your patient, and then also trusting when you don't understand something, like reaching out for help. And in at least my experience, I can say that all the intensivists and anybody who I ever reached out to for help, like they were more than willing to provide help. And I think any doctor or physician or medical service understands that this is a time that we need to make ourselves available and be helpful to other team members. And so I think everyone is going to be very approachable and just reaching out for help when needed. And you don't need to feel alone in this. So, any challenges, I think, can be overcome with that mindset.
Well, guys, that was absolutely incredible. I'd like to thank both of you for your service and for joining us today to share your experiences in this conversation. Arvind, I know you're pursuing a head and neck fellowship next year, and Usman, I know you have some time to decide, but it's clear to me, and I'm sure to all of the listeners, that you both have very promising futures. So thank you again. To the listeners, I encourage you to visit the COVID-19 resource page at entnet.org and also join the conversation at ENT Connect, where we are sharing information and inspiration as we get through this crisis together. Now, as always, we are one. Thank you.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.